name's Leah Kramer. I'm a social worker. I work at Georgetown University's Hemophilia Treatment Center. I'm deep into my second year there, which I completely appreciate on this call. This makes me the absolute greenest person when it comes to bleeding disorders. One of my great joys, though, is the fact that I get to learn so much, and it's entirely coming from the patients, I find. So when I'm meeting with you in these comprehensive visits, not only am I getting, the education about, the disease process and everything else, but you tend to be almost without exception, extremely willing to share your stories and experiences. And I've noticed through my work that includes a lot of information, a lot of stories about medical trauma. So when I was approached to do this presentation, I was very excited, and I felt like there was a lot to dig into. So this is what we'll be talking about today. First, we're going to talk about defining medical trauma and its effects. What is it, and what does it look like? Then we'll discuss trauma-informed care, which is the healthcare system's response to addressing trauma with patients. And then we'll get a little bit more granular and discuss how trauma works in the brain and body. And then talk a little bit more about how this can, unfortunately lead to some behavioral health issues like depression, anxiety, and specifically PTSD. And just want to give you a heads up that, I will be talking about issues around psychiatric diagnosis. And if this is an issue that is particularly sensitive to you or a great challenge, feel free to bow out for a few minutes, get yourself a drink of water, whatever you need to do, and then, maybe rejoin us a few minutes later. And then there's an actual study that examines the incidence and experience of people with hemophilia and PTSD. And then we'll talk about, what are some practical tools? How do we cope with trauma? What are things that we can do immediately? And maybe what do we look for in providers who can help us address this? And then finally, we still need to go to the doctor's office. We still need to go back into the medical setting. And what are some things we can think about, as we, go back into the office and have to have some of these conversations with our providers? So medical trauma involves a set of negative physical and psychological reactions to medical illness, procedures, and treatments. It stems from a negative internal experience of medical care. So first and foremost, medical trauma is a result of these negative experiences. And the experiences can be extremely varied. They could be you're having a terrible bleed, a traumatic surgery. It could be the result of a medical error. It could also just be from a really negative interaction with healthcare providers where you feel like you're not, your medical needs are not being addressed properly. Important to note that medical trauma itself is not a diagnosis. I'm using the term very broadly. It can, however, lead to certain diagnoses. It can lead to PTSD, depression, anxiety, can even lead to chronic pain. But again, all these diagnoses that it could lead to would need to be made by a medical professional, behavioral health professional, or physician. And also important to note that the experience of medical trauma is subjective. So you and I can have the exact same experience of trauma, but process it very differently. Bottom line is, if you have an experience that feels traumatic and you identify it as traumatic, nobody can tell you that it is not trauma because they are not you and they're not having your experience. So this is a list of some of the symptoms of medical trauma. It is not complete. This is really, I think, the most common ones that we find. It also can vary greatly in intensity. The first two here I'm going to be addressing a lot in this presentation, which is a fear and distrust of medical settings and medical staff, and avoidance of medical settings or procedures. It can also lead to some, emotional symptoms, depression and anxiety, numbness, anger and irritability. It can manifest itself in a very physical experience, so experiencing pain, sweating, feeling sick or discomfort. It can disrupt your sleep. And then finally, repetitive negative thoughts about your experience. So if you've experienced trauma, you know that it is something that keeps you sort of basically stuck, and it feels very difficult to move beyond. And so you tend to ruminate and continue to focus on that traumatic event. So trauma-informed care, as I said, is the medical community's response to people with trauma. So awareness of how trauma affects us really started in the 1970s. We had combat vets, returning from Vietnam, and they started to see a lot of symptoms that seem to present over and over again. Substance use, flashbacks, mood dysregulation, a lot of suicidal behaviors as well. And providers started to recognize, well, this is, these two are directly, are one causes the other, basically. And then ultimately, they found that you don't really have to be a combat vet to experience trauma, obviously. That this can also relate to people who've endured childhood trauma, abuse, neglect, people who've been in accidents, victims of crime, and obviously medical trauma falls under that umbrella. Around Y2K, they started to do a lot of research and did all these studies that demonstrated that there were really profound health outcomes, meaning there was a shorter lifespan, that there are greater incidences of severe illness, all related to trauma. So they said, you know what, we really have to figure out a way to respond to this. So trauma-informed care recognizes and responds to the signs, symptoms, and risks of trauma to better support the health needs of their patients. And it takes active steps to avoid re-traumatization of the patient in the healthcare setting. Naturally, healthcare setting is supposed to be a safe place, a place of healing, right? Do no harm, but it's really, when you're thinking about medical trauma, it's almost impossible to imagine that the healthcare setting is free from the risk of re-traumatization. So a response to that would mean creating an environment that feels safe for patients. So that means, creating a place that honors privacy, and it feels more collaborative. So we don't have, directive care where the doctor is telling you what to do, but it feels more like a collaboration between the doctor and patient. And then it adopts the assumption that all patients should be considered to have a history of trauma, because it is just that common. There is no demographic group. There certainly are some that are at higher risk for trauma, but there is no demographic group that is free from risk. And it just, generally speaking, is a better way to conduct healthcare, right? The big distinction that we like to make in trauma-informed care is switching the mindset from what is wrong with you to what has happened to you. And what we mean by that is, if you have a patient who has a history of trauma and they're coming into the doctor's office, they often have a set of behaviors that providers find to be extremely frustrating, confounding. Like, what is wrong with this patient? They could be combative, they could be withdrawn, they may be missing appointments, maybe they are abusing substances. And so almost the natural reaction is to focus on those problems and say, what this patient needs to fix these problems so that they will be healthier, right? Not appreciating that each of these behaviors are actually adaptations. They're things that patients have learned to do to essentially survive and prevent further harm, right? And so if you as a practitioner, anybody in the healthcare setting recognizes that if you approach it from what has happened to you, just pausing to reflect that there might be conditions in this person's life, experiences that they've had that impact their behavior, then you're going to be in a much better position to respond to that. So I feel like I would be committing malpractice if I left this slide out. When it comes to medical trauma, and we're talking about the bleeding disorder community, we cannot skip over this topic, right? the big trauma is the contaminated blood scandal. Again, I think anyone in this call could present this slide better than I can, and you know about the history, the fact that we lost essentially, I guess, half the population to these contaminated products back in the 80s. So these life-saving treatments became the source of deadly infections. Adding insult to injury, the community became subject to stigma and discrimination. We all know about Ryan White and how everybody really struggled with the aftermath. And then distrust in healthcare providers. So this was, as I talked about in that first slide, this distrust of the medical system and how that may affect your decisions in your healthcare. So if you lived through this crisis, maybe you're less likely to consider a new product, or maybe you're less likely to consider prophylactic treatment, thinking that there may be risks. So obviously it can have, a profound effect on your health and your interaction with the healthcare system. And then the other group that I would, be remiss if I didn't mention is women. And we know that in the bleeding disorder community that women have long been, gaslit essentially about their diagnosis, and women often have to present to emergency departments or and essentially any other provider who's not a hematologist, and have to defend themselves and explain themselves, right? If somebody doesn't have that background in hemophilia, all they just remember those little tidbits like this is an X-linked disease, therefore, this is really primarily experienced by men, and women are carriers, really minimizing the effect, and obviously that affects the treatment that they're given. We know that women tend to get diagnosed later. I read a study where women with moderate hemophilia get diagnosed about 6.5 months later. Women with von Willebrand's have to wait 16 years between their first symptoms and the diagnosis, which frankly doesn't make a whole ton of sense since they're more likely to experience symptoms earlier than men. And then pain, right? Pain is an issue across the board for women, because they're less likely to be, to have their diagnosis, fully understood and appreciated. And women in general tend to have their pain addressed at lower levels than men. And so often what we see is that when women present with pain, it's often treated as a behavioral health issue, right? Maybe they're more likely to be treated with antidepressants when they have a real legitimate medical condition. So here's where I'm going to talk a little bit about, again, I said the granular, about how trauma works in the brain. So we have something wonderful, which is the stress response system. This is something we all have, and it allows us to function. It keeps us safe. It's just part of the human condition. But we know that trauma can dysregulate that stress response system. So when it's working properly, we have a stressful event, our amygdala goes into action. It activates the fight or flight response. It allows us to be safe. And then when the danger is no longer present, then the parasympathetic system can take over. The attention goes from the amygdala to the prefrontal cortex, which is the thinking part of our brain, allows us to relax and have rational thoughts, right? And so as we go through our day, our week, we have moments between the sympathetic and the parasympathetic nervous system, and that allows us to function. But what trauma can do and how it dysregulates it is that it causes your brain to remain in a state of hypervigilance and respond to situations that aren't actually dangerous. So it's like you have a prophylactic dose of stress hormone, of cortisol, norepinephrine, so that if something even reminds you of a danger, then you become dysregulated and have a lot of these symptoms I talked about in the first slide. So, an example of that in the healthcare setting, it's pretty straightforward. If you have an experience of a very traumatic bleed, you're going to take in the sights and smells and sounds in a hospital. Even if you're not conscious of it, your body is sort of learning about all of these cues. And the next time you're in a situation that even reminds you of it, you're going to become activated and develop these symptoms. And so this can happen just if you're just going to the doctor's office, perfectly fine, no bleeds, but there's that experience of having that trauma can activate that system. And we know that severe trauma can actually work to create changes in the brain. So it can effectively rewire your brain. The good news is if you follow up and get some good treatment, some good behavioral health care, you can go back into the other direction. And we also know that trauma affects our health, right? So trauma is in the HPA axis, which involves all of these these hormones. And so when we have trauma, we are more likely to have increased cortisol. And that cortisol can lead to depression and heart disease. Oxytocin is that feel-good hormone. And unfortunately, when there's trauma, we have less of that in our system. And that is a protective hormone. And so when we have lower levels of oxytocin, we are more likely, for example, to develop a substance abuse disorder. Inflammation, again, a natural function of our body. In response to injury, it's very normal, but again, with trauma, we are more likely to have even more inflammation, and that can lead to autoimmune diseases and heart diseases. And then finally, these unhealthy habits I talked to, smoking, drug and alcohol abuse, overeating, they're all adaptations to deal with trauma. So, feeling those symptoms are very uncomfortable, and we're going to do everything we can to avoid them, to feel better and to feel safe. And so these adaptations, obviously, while they help us in the short term, can have a very negative impact on health. So what happens when these symptoms become severe is we can start to talk about post-traumatic stress disorder. So I'm going to go over these 4 buckets of symptoms, but I really want to caution you to not do any self-diagnosis here. If you have any level of experience of trauma in any forms, or even if you're just a human being at all, you're probably going to see some of these symptoms that look familiar to you. But I just wanted to throw these out there just to give you a sense of the symptoms that are associated with trauma. So first is the intrusive thoughts and memories. So this means like reliving the event. So it could be flashbacks, recurrent, unwanted, distressing memories. And in bleeding disorders, it can actually be more future oriented. So it could include an intense fear of an upcoming procedure, an appointment, of getting worsening symptoms. You might be afraid of future accidents. And maybe you're worried about possibly passing the disease on to future generations. The next is avoidance. And avoidance, I kind of think of it as the flight part of fight or flight. So this is trying to avoid thinking or talking about the traumatic event. That means avoiding places, people, any experiences that remind you of the trauma. So when it comes to medical trauma, this could mean delay in contacting your provider, not taking medications, delaying surgeries, missing appointments. And again, it could also lead to abusing substances. So negative cognitions and mood. This is what we think about feels a little bit more like depression. It means having negative thoughts about yourself, hopelessness about the future, a lack of interest in things that you once enjoyed, feeling numb, feeling guilt, and having suicidal thoughts. And then the last one is arousal reactivity. And this is kind of the fight part of fight or flight. So it might be tied if you have a pain, there's something in your body that feels very painful, then that can activate the arousal reactivity, and that can lead to irritability, angry outbursts, aggressive behavior, engaging in reckless behavior. We talked about avoidance, where you're like trying to avoid the doctor. In arousal reactivity, you might have the opposite problem, which is you may be more likely to constantly be on the phone with the doctor, showing up to the ER more often, really obsessing and being even more attentive to your healthcare needs. So there's a social worker in HTC in Boston, and she was curious. She had gone to a class on PTSD for her continuing education, and she wondered if there would be, her suspicion was that there would be a relationship with higher rates of PTSD and hemophilia, and she was right. She found that the incidence of patients with hemophilia, it's 3 times the level of the general population. And it was medical events like bleeds or acute hospitalizations that were most frequently identified as the traumatic events experienced by those with hemophilia. So again, the trauma can be a whole, bevy of experiences, but it's the bleeds and the acute hospitalizations that were more likely to lead to PTSD. And found that people who were at greater risk if they were younger, lower levels of education, and people with comorbidities, including HIV, hepatitis, nephropathy, and inhibitors. I was curious about the age and the education level, and apparently that is just consistent with PTSD in the general population. So the result of the study is she said, hey, HTCs, we really need to be better about making sure that we are looking for this in our patients and really having these conversations, doing a better job with screening, and then working with the patient to make sure that they have the tools and the resources they need to respond to it. So I wanted to talk a little bit about avoidance because I imagine, if this is really problematic, if you have a history of trauma and you have a chronic condition, because obviously avoidance is going to lead to bad things. We're not going to get the care that we need. So let's say, for example, you have a knee replacement surgery. It's got to be done. You've been putting it off for a while, but your traumatic memory is having a surgery when you were much younger that went very badly. And so anticipating the surgery can lead to all sorts of uncomfortable feelings in your body. Maybe you are having a harder time getting along with your family. You're not sleeping well, and you just want the misery to go away. So what do? Call up the surgeon and maybe delay the surgery, cancel it. What you get there is a short-term relief from anxiety. Whew, all the symptoms seem to go away for the moment. You can get back to that rest and digest as opposed to the fight or flight. It feels good in the moment. But what happens, obviously, is that your brain has learned it cannot tolerate having a surgery, that it is extremely dangerous, and it actually makes your anxiety worse. And so the avoidance really leads to increased levels of anxiety and decreased confidence that you're going to be able to manage going forward. So what do we do about it? Well, I would imagine if you're experiencing any of these symptoms and you feel like it's getting to the point where it is impacting you or getting in the way you're functioning, or you're just not feeling your best, is to go talk to your social worker, your HTC. If you already have a behavioral health provider, that's great. If not, this is our wheelhouse as social workers, to be able to address this with you. If you have any of these symptoms, I may strongly recommend psychiatry. They can provide a diagnosis, and a diagnosis is good because that can guide treatment. And oftentimes these symptoms are very responsive to medication, but any psychiatrist worth their salt is also going to make sure that you are connected with a therapist to help address the underlying trauma and to give you tools to cope with it better. I don't think we can see it in the slide, but the 2 forms of therapy that are most recommended for trauma that I have learned about is CBT, cognitive behavioral therapy. There's CPT, which is a form of cognitive behavioral therapy, more strongly associated with trauma. And then EMDR, eye movement and desensitization and reprocessing therapy. And then, of course, support groups. you guys know better than anyone that connecting with people with the same experience as you is going to be extremely helpful, especially when it comes to processing the trauma. And then some strategies to combat the stress response. I was presenting to a group of internal medicine residents about trauma-informed care, and I showed them this slide, and it was sort of funny about it. I mean, this is a guide for like basically managing stress, but it's also sort of a guideline for all human beings, right? We all need to engage in these practices because they're proven to reduce stress and improve mood. And if you look at them, yes, sleep, nutrition, getting out in nature, mindfulness, they seem sort of obvious, but it's important to check in and make sure we're really engaging in this on a regular basis so that we can reduce our stress level. And additional strategies to address anxiety. We know that anxiety is an experience that is not just emotional, but we feel it physically in our body. So deep breathing exercises are very important because that rapid breathing is a stress response. Grounding techniques can be extremely helpful. That is important if you're experiencing panic symptoms. And the whole point of grounding techniques, and we can talk about it later in Q&A if you're interested, but it's an opportunity to stay focused in the moment, because a lot of times when we're anxious, our thoughts kind of go out of control, either to the fears about the future or some worries about the past. Progressive relaxation techniques are also wonderful. It's an exercise where you tense and relax your muscles when you are feeling calm. So you retrain the brain that tense muscles don't necessarily mean danger. Mindfulness exercises and meditation, of course, are wonderful. They are evidence-based to reduce cortisol, that stress hormone. Again, focusing on the breath. And then Tai Chi and yoga are just great forms of exercise because they keep your mind engaged and, again, also focusing on the breath. So these are all good techniques to help with anxiety that you can sort of, practice pretty much anytime. I'm going to skip this for now just because of time. Important to know that medical settings, it can be triggering, right? So maybe step one is learning or just paying attention to what your specific triggers are. So a lot of times we'd like to say that simply saying what you fear out loud can take away a bit of its power, and it allows you to prepare better for it. Medical settings, and by the way, I picked this picture. It looks like it came from a horror film. I mean, there's something kind of scary about doctors' offices. Again, with the sights, sounds, and smells, they can be very triggering. Invasive procedures and vulnerable positions. This doesn't necessarily have to be in a hematologist's office. It could be in any medical setting. Asking of personal questions, and possible power dynamic between the provider and the patient. And finally, a loss of privacy. We try to be as best we can in medical settings, to honor privacy, but obviously it can never be absolutely perfect. So communication styles, passive, aggressive, and assertive. And I know everybody in this call is familiar with all of them. And none of us is perfect, and none of us can say that we have been assertive 100% of the time, but it's good to be mindful and to consider how you communicate to your physician and your healthcare team when you come in. So passive communication is, what I think about when we think about flight, right? That's avoiding expressing opinions or feelings. So when you're going into their doctor's office, your primary objective is to just get out of there, right? You don't want to linger. You just want to get out of that office, right? And so maybe the best way to do that is the path of least resistance, and that means that you just nod, don't make eye contact. Whatever the doctor says you agree with, and again, all serving just to try to get out of that office. So, whatever you think is best. And what happens at the end of that is that you become extremely frustrated, right? Your needs are not being met. You waited all year for this appointment, you get in there, and then you're basically, the concerns that you have been unaddressed. And that could lead to a lot of frustration. And maybe the next time you're going to be a little bit angry about it, right? Aggressive communication means that I really need to get my needs met, and I'm going to do anything I can to get there, right? So expressing opinions that might violate the rights of others. So this means being loud, demanding, hostile. Yes, you may get your needs met because, you're being rather, strident about it, but it can also do great damage to that therapeutic alliance. This is a person in front of you who has a level of expertise and really does this work to try to help. But if you carry on in an aggressive way, that can do damage to that relationship. And also, again, if you're being aggressive and you're in that fight level, with the amygdala, you're not really using the thinking part of your brain, so you're not able to get the most out of that appointment. So, example, you need to get me my prescription or I'm going to sue this clinic, right? Probably not going to be the way you want to go. And then finally is assertive communication. And that's where you are expressing your feelings very clearly and you're respecting the person sitting in front of you. You're using, instead of you statements, you're using I statements. So you're being truthful to what your needs are, but you're also sitting in an exchange with a provider so that you are going back and forth. And you're balancing listening with stating your needs. So an example, which I might not be able to see here, which is, I am feeling rushed. Can we slow down and review this process again? Right. It's perfectly okay to do that. Right. And if we're not being assertive, again, what is the value of that appointment? And from your provider's perspective, they much prefer assertive communication, because if you are passive or you're aggressive, your health outcome is going to simply be worse. Right. So addressing medical trauma with your provider. So here we are in the doctor's office. What are some things we can do, right? Other than work on our communication skills? Well, we want to be assertive with our doctor. It might be worth, if you are comfortable, to address the concern of your trauma. Like, listen, I've had this experience in the past and it's made me feel really uncomfortable. I feel like I'm not being listened to or taken very seriously. I've had doctors dismiss me. And so I just want you to know that's been my experience. And I'm sort of fearful I'm going to be dismissed again today, right? That gives an opportunity for your doctor to respond and really focus on what is more important to you. And then if you are being mistreated, please speak up, right? It's important, not only, again, because you need to get good patient care, but you may also be doing this in service to your other patients in the clinic who may be having a similar experience. So if you feel comfortable, you can go to a member of the treatment team that you maybe are more comfortable with, if it's a social worker or if it's a nurse. But also clinics tend to have an ombudsman or a patient advocate that you can go to address this. Also recommend bringing a list of questions to share with your doctors. Your doctor they have their own agenda that they have to get through. Sometimes you're both feeling rushed for time, which is why it's important to have those questions ahead of time in order of importance, recognizing you may not get to everything on the list, but you want to make sure, again, that you're not leaving that office feeling frustrated or dismissed. Like, the things that are important to you have to be addressed. And then finally, consider a family or friend to come with you as an advocate, right? It's good to have an extra set of ears because we can miss things. If you're, again, feeling very, very anxious, it is just nice to have that supportive presence at your side, and maybe someone who can also speak up for you when it's necessary. So with that, thank you for your time. I want to apologize. My dog was scratching there at the end. I got a bit distracted, but thank you for staying with me.